everyone. Welcome to another episode of Sinescuela. So for today, our topic would be annular pancreas. So for the case study, the patient is an 11-year-old girl which presents with annular pancreas. So the patient has a 10-year history of early satiety and recurrent vomiting after a meal. She had been treated symptomatically with clinical diagnosis of chronic gastroenteritis for her recurrent vomiting. So the patient underwent physical examination, laboratory examination, abdominal ultrasound, abdominal computed tomography, and attempted laparoscopic duodenostomy. So the patient weighs 42 kilograms and her height was 142 centimeters. Next slide, please. So in her laboratory examinations, her results for white blood cell count, hemoglobin count, and albumin were within the normal range. So was her serum and urine electrolyte levels. For her abdominal ultrasound scan, it was also normal. Next slide, please. However, her upper gastrointestinal study exhibited a distended duodenal bulb, which was partnered with a diffusely narrowed second portion of the duodenum, suggesting extrinsic comprehension of the duodenum. So, for the patient's abdominal computed tomography, it exhibited pancreatic parenchyma that was surrounding the second portion of the duodenum. This then caused the diagnosis of the annular pancreas. So, laparoscopic duodenostomy was also attempted. However, adhesion between the annular pancreas and transverse colon was dense that precluded laparoscopic approach. Next, please.
So before we actually move on to the annular pancreas itself, let us discuss the gut tube first. So let us discuss the divisions of the gut tube first. So as a result of cephalocaudal and lateral folding of the embryo, a portion of the endoderm derived from gastrulation is incorporated into the embryo to form the primitive gut. In the cephalic and caudal parts of the embryo, the primitive gut forms a blind ending tube, the foregut and hindgut respectively. And then the middle part, which is the midgut, remains open and temporarily connected to the yolk sac by means of the vitelline duct or yolk stalk. Further folding and growth of the embryo causes the communication of the gut with the yolk sac to continue to get smaller and the regions of the gut, which is the foregut, midgut, and hindgut, to become further refined. So next slide, please. So these are the derivatives of the gut regions. And since we are talking about the annular pancreas, we are gonna, of course, focus on the pancreas, which is gonna develop in the foregut.
So now let us talk about the molecular regulation of the gut tube. So regional specification of the gut tube into different components occurs during the time that the lateral body folds are bringing the two sides of the tube together. Specification is initiated by a concentration gradient of retinoic acid, or RA, from the pharynx, which is exposed to little or no RA to the colon that sees the highest concentration of RA. This RA gradient causes transcription factors to be expressed in different regions of the gut tube. Thus, PDX1, or pancreatic and duodenal homeobox 1, specifies the duodenum and pancreas. This epithelial mesenchymal interaction is initiated by sonic hedgehog expression throughout the gut tube. Sonic hedgehog expression upregulates factors in the mesoderm that then determine the type of structure that forms from the gut tube, such as the stomach, duodenum, small intestine, and so on.
For the molecular regulation of the pancreas, the fibroblast growth factor 2 and activin, which is a transforming growth factor beta family member, are produced by the notochord and endothelium of the dorsal aorta. And these two repress at the sonic hedgehog expression in the gut endoderm, which in turn forms the dorsal bud pancreas. Meanwhile, the ventral bud is induced by the visceral mesoderm, and as a result, the expression of the pancreatic and duodenal homeobox 1 or PDX1 gene is upregulated. Although all of the downstream effectors of pancreas development have not been determined, it appears that expression of the paired homeobox genes PAX4 and PAX6 specifies the endocrine cell lineage such that cells expressing both genes become beta cells that secrete insulin, delta cells that secrete somatostatin, and gamma cells that produce pancreatic polypeptides, whereas those expressing only the PAX6 gene become alpha cells that secrete glucagon. So one of the derivatives of the foregut is the pancreas. The pancreas is formed by two buds, the dorsal and ventral, originating from the endodermal lining of the duodenum. Most of the pancreas is derived from the larger dorsal pancreatic bud, which appears first and develops at a slight distance cranial to the ventral bud. The dorsal pancreatic bud is located in the dorsal mesentery, while the smaller ventral pancreatic bud develops near the entry of the bile duct into the duodenum and grows between the layers of the ventral mesentery. In the normal development of the pancreas, the duodenum rotates to the right and becomes C-shaped, and the ventral pancreatic bud moves dorsally in a manner similar to the shifting of the entrance of the bile duct. The ventral bud comes to lie immediately below and behind the dorsal bud. The parenchyma and the duct systems of the dorsal and ventral pancreatic buds then fuse. The ventral bud forms the uncinate process and the inferior part of the head of the pancreas. The remaining part of the pancreas, which is the superior part of the head, the body, and the tail, is derived from the dorsal bud. As the pancreatic buds fuse, their ducts, anastomose, are open into one another. The main pancreatic duct is formed by the distal part of the dorsal pancreatic duct and the entire ventral pancreatic duct. The proximal part of the dorsal pancreatic duct often persists as a small channel, the accessory pancreatic duct. The entrance of the accessory duct is at the site of the minor papilla, located approximately 2 centimeters cranial to the main duct. The main pancreatic duct, together with the bile duct, enters the duodenum at the site of the major papilla. For the histogenesis of the pancreas, the parenchyma, which is the basic cellular tissue of the pancreas, is derived from the endoderm of the pancreatic buds, which forms a network of tubules. Early in the fetal period, pancreatic acini, or the secretory portions of an acinous gland, begin to develop from cell clusters around the ends of these tubules, which are the primordial pancreatic ducts. In the 3rd month of fetal life, the pancreatic islets develop from groups of cells that separate from the tubules and lie between the acini. Recent studies show that the chemokine, the stromal cell-derived factor 1, are expressed in the mesenchyme, which controls the formation and branching of the tubules. The expression of transcription factor neurogenin 3 is also required for the differentiation of pancreatic islet endocrine cells. And approximately by the 5th month, insulin secretion begins. Glucagon and somatostatin secreting cells also develop from parenchymal cells before the differentiation of the beta cells that secrete insulin.
So now let us discuss an abnormal development of pancreas, which is the annular pancreas. So annular pancreas is a congenital anomaly characterized by partial or complete circumferential encasement of the second part of the duodenum by a band of pancreatic tissue during embryogenesis. The surrounding pancreatic tissue may cause obstruction in digestion, but many of the patients with annular pancreas stay asymptomatic and are only diagnosed via imaging. However, a fraction of patients with AP tends to present with clinical manifestation either early in life or during adulthood, usually between 20 and 50 years of age. So annular pancreas is not commonly encountered in clinical practice and affects both children and adults. So according to Feldman, annular pancreas is estimated to occur between 1 in 1,000 raised to 92 to 94 and 3 in 20,000 raised to 95 to 96. So next slide, please. So precise etiology implicating the development of annular pancreas is not well defined due to its rarity, but annular pancreas is considered to be an embryopathy. Molecular investigations have shed light on some of these theories, confirming that the origination of the annular tissue is from the ventral pancreatic bud. The development of annular pancreas is proposed to be a migration anomaly resulting from the failure of the ventral bud to rotate and extend to encase the second portion of the duodenum either partially or completely. So also overexpression of the ventral specific gene transmembrane 4 superfamily member 3 or TM4SF3 has also been associated with annular formation. So next slide. Studies strongly show that genetic factors are involved in the pathogenesis of annular pancreas. There are reports of annular pancreas occurring in siblings and identical twins, and a microduplication on chromosome 6q24 encompassing the utrophin gene was detected in a mother and her child, both of whom were diagnosed with annular pancreas. Moreover, annular pancreas is more common in patients with other congenital anomalies such as trisomy 21, cardiac defects, malrotation, and tracheoesophageal fistula.
So for the symptoms of annular pancreas in infants, it is associated with significant duodenal constriction, so non-bilous vomiting, bloating, and feeding intolerance. While in adults, it's the abdominal pain, pancreatitis, evidence of biliary obstruction, nausea, vomiting, and bloating. So for most people diagnosed with annular pancreas, symptoms are not that present. However, having an annular pancreas is linked to having Down syndrome, where about one fourth of the population diagnosed with annular pancreas also have Down syndrome. Next slide, please. So for the diagnosis, even if the baby is still unborn, annular pancreas can be identified through the use of an ultrasound. So although the annular pancreas is often diagnosed prenatally or during infancy, it is inaccurate to consider it solely as a disease of infancy. So diagnosis in children is suspected by findings on abdominal radiographs, ultrasounds, or upper gastrointestinal series. So in adults, CT scan, MRCP or magnetic resonance cholangiopancreatography or ERCP, which is endoscopic retrograde cholangiopancreatography, may be more commonly used. Not infrequently, the diagnosis of annular pancreas is made at laparotomy, a surgical incision in the abdominal cavity. So this is performed to examine the abdominal organs and aid diagnosis of any problems.
So for the treatments, there are three possible surgeries that can be performed to a patient with annular pancreas. So the first one is the duodenostomy. So the conventional surgical treatment for annular pancreas has always been duodenostomy, which is done by connecting the portions of the duodenum before and after the obstruction, bypassing the obstructed duodenum. So this is done on either side to side or diamond shape to avoid major ductal structures that traverse the pancreatic tissue. So this type of surgery also causes fewer chances of anastomotic site ulcers than the gastrojejunostomy, which we'll be going to discuss later. So this is also the surgery that is employed in neonates and children, and in this case report, this was the surgery that is applied. Next slide, please. So for the gastrojejunostomy, the anastomosis is created between the stomach and the proximal loop of the jejunum. So this is usually done either to drain the stomach's content or in the case of annular pancreas, to provide a bypass for the gastric contents. So a study conducted by Vidal first reported successful gastrojejunostomy in a 3-year-old patient with annular pancreas in the year 1905. So gastrojejunostomy is recommended in adult patients due to less mobility of the duodenum. So a variant of gastrojejunostomy, also known as the laparoscopic gastrojejunostomy, has been widely performed in patients with obesity or those with gastrointestinal cancers. So again, trivia, laparoscopy is a type of surgery that checks the problem in the abdomen. So in this surgery, a laparoscope, which is a thin tube, is inserted into the abdomen through a small incision. So since one of the complications of gastrojejunostomy is the risk of developing an ulcer of the anastomotic site, a vagotomy can be incorporated in the surgery. So vagotomy is a type of surgery that removes all or part of the vagus nerve. So next slide. So last is the duodenojejunostomy. So this is a surgery in which the compressed portion of the duodenum is released and an anastomosis is created between the duodenum and the jejunum. So just like the duodenostomy, this type of surgery causes less anastomotic site ulcer compared to that of the gastrojejunostomy. So aside from that, just like the gastrojejunostomy, duodenojejunostomy is recommended in adult patients due to less mobility of the duodenum. So the minimally invasive procedures mentioned earlier are generally performed due to less post-operative complication and a short recovery time. However, following surgical repair, there appears to be an increased risk of acute and recurrent pancreatitis in adulthood. So aside from this, an ongoing cancer screening and surveillance should still be considered in adults since an association with duodenal carcinoma has been reported in the study conducted by Moon in the year 2017. Next slide, please. So for the interventions, there's no possible way to prevent the annular pancreas from happening since it's a condition that occurs during the development in the womb. However, a mother can take steps to ensure a healthy pregnancy for a healthy baby. So the following are the possible steps that a mother can do. So healthy balanced diet, visiting the doctor regularly, avoiding cigarettes, not taking over-the-counter medication, staying hydrated, and avoiding alcohol. Next slide. That would be all. These are the reference that was used for this report. That would be all. Thank you.
So that ends our episode for today. Thank you and God bless.